Welcome everyone to our Project Echo session today. We're so excited to have you with us for our 7th session on addressing barriers to healthcare and cancer prevention screenings for adults with intellectual and developmental disabilities. My name is Michelle Jansen, and I'm a community outreach coordinator here at Rutgers Cancer Institute of New Jersey. And as the state's only NCI designated comprehensive cancer center, our goal is always to prevent cancer before it starts. In New Jersey, cancer is the second leading cause of death. 1 in 2 men and 1 in 3 women within our state will develop cancer at some point in their lives. We know that those with an intellectual or developmental disability experience a greater number of health disparities that can then lead to a reduced rate of cancer prevention screenings and a higher number of later stage diagnoses. Before we introduce our moderators and presenters for this session, we would just like to share a few tidbits of information about our Project Echo series, especially if this is the first time you're joining us today. We encourage everyone to have their cameras turned on if possible to encourage the flow of dialogue, as well as the exchange of information and resources throughout the session. We would also just like to give a gentle reminder to be sure that you're muted when not speaking, just to minimize any potential background noise. But we do encourage you to unmute yourself at any time to really share your thoughts, your suggestions. We'll be doing a lot of dialogue throughout this session. We also have a chat box, so if you'd like to add any comments or questions into the chat box, we encourage that as well. So we'll actively be monitoring that chat box during our session today. So the first part of our Project Echo session will involve an evidence-based presentation by Alicia Mirra that will then lead us into an open conversation about best practices and developing solutions for common challenges that we may face in our practice and provision of services to individuals with special needs. Everyone in our room today is an expert within their own right, and also through their own unique set of skills and experiences. Our goal is to bring all of these combined skill sets and experiences into one place where we can discover new approaches, build a set of evidence-based practices, as well as to share resources and connections to enhance the care that we provide in our respective disciplines and professions. I'd like to introduce our panel of moderators for each of our Project Echo sessions. And we're also going to be sharing a link with everyone after the final session next week's series that will have all the recordings, all the PowerPoint presentations, and we have resource guides for each session as well. So before we get started, I would love to introduce my wonderful colleague, Laura O'Reilly-Stanzilis, who's one of our Project Echo moderators from the North Jersey Health Collaborative, and Laura is currently the Executive Director. Welcome, Laura.
Thank you, Michelle. Welcome everyone today. Michelle, I'd like to share also, this is being recorded and this will be provided as a resource as well as being posted on the North Jersey Health Collaborative Resource Library. We have approximately 70 people, 70 people who have been part of this Project Echo, and each week we have different groups of people. So the audience for today's presentation and all of the presentations that are being archived will be shared, again, will be larger than the audience at the individual weekly meetings. So I just want to share that when I first met Alicia and asked her to be part of this, I was fascinated by her work and her warmth and the knowledge that she brought to this conversation. And I've been working with individuals with disabilities for many years, and there's a lot that I really didn't understand until Alicia shared her information with me. I'm going to read her very impressive bio to you, and she is going to talk about patient privacy and confidentiality. Alicia Fiore Mirra is a clinical psychologist, and she's licensed in the state of New Jersey. She has worked with children and adults with intellectual and developmental disabilities for over 25 years in various capacities, including teacher, therapist, consultant, and as a mom. Dr. Mirra earned a Bachelor of Science in Special Education and Psychology from Seton Hall University. She graduated from Drexel University with a Master of Science and a PhD in clinical psychology, specializing in intellectual and developmental disabilities. Prior to her most recent position, she served as the coordinator of behavior services for Devereux, New Jersey. Dr. Mirra has served for the past 3 years as the psychologist for Atlantic Health's Developmental Disabilities Center, where she provides assessment and treatment services for adults with IDD as part of a multidisciplinary team. Thank you, Dr. Mirra, for all that you do, and thank you for being here today. Welcome.
Thank you so much, Laura. I am so thrilled to be here. As I mentioned this morning, listening to all the insightful and informative presentations over the last several weeks, I have never felt more proud to belong to this community. So I thank you for having me here today. It really is an honor to be speaking with all of you today. I'm really excited to be talking about patient privacy and confidentiality because it's such an important topic, an issue. And I think it's one of those things where we don't give it too much active thought on a regular basis. I think we all know about privacy and confidentiality. We know our responsibilities and obligations. And I know everyone on the call is practicing in a legal and ethical way. So we sort of have that covered. But I don't think we always bring it to the forefront of our minds to focus on how can we maximize privacy and confidentiality for our folks, for our individuals. So I'm hoping that, just give me 1 second because I apologize. Oh, there's my button. Okay. So my goal today is really just to raise our awareness of some of the issues related to privacy and confidentiality, because our adults with intellectual and developmental disabilities really need protections in certain ways that the non-disabled communities may not need. So really to get us thinking more about it and maybe coming up with some ways that we can be more proactive, as I said, to maximize those rights. So we're going to look at what privacy and confidentiality really mean, why they're so important in general, and really more specifically to our folks. We're going to look at some of the threats to privacy and confidentiality, and then hopefully discuss some of the strategies that we can use to better protect privacy and confidentiality. So just to give you a little bit more of an idea of the perspective from which I'm going to be speaking today, I am, as Laura mentioned, I'm the psychologist at the Developmental Disabilities Center at Morristown Medical Center, and I work as part of a multidisciplinary team. So I'm the psychologist. We also have a psychiatrist and primary care physicians. I'm on the behavioral health services team, and we serve adults with intellectual and developmental disabilities under a grant from DDD. So we do require that all of our patients be age 21 or over, that they are registered with DDD, and they all of our patients have either Medicare or Medicaid as their primary insurance. My role here primarily is to provide assessment and individual therapy. A lot of what I do is collaborating with the care teams. So not just the care team here, but my patients' teams. So I work very closely with their caregivers, their family members, DSPs, managers of group homes, vocational programs. I really see myself as part of their team. So coming from this perspective, you'll hear me refer to our individuals as patients. I am aware, and Laura mentioned this a little bit earlier, that there is other terminology out there. And I'm originally from the special education world. So I've used terms from students, consumers, clients, individuals. So You can kind of fill in the blanks with those other terms as we talk today, but since I'm working within a medical model, you'll hear me refer to folks as patients. So let's start by looking at what privacy and confidentiality mean. Those terms are generally used together, and they do work very closely together. They usually come hand in hand, and sometimes they overlap, but they are two distinct ideas. So when we talk about privacy, we're talking about things that apply to the person, directly to the person. Privacy is the control that we have over who knows us and who knows anything about us. Just as members of society, we all have a certain right to privacy, right? So we, close the curtains or close the blinds so that the neighbors can't see what we're doing, or, we have phones that are not tapped in this country, so people can't hear our conversations. So we have a certain right to privacy, and that right is a legal right. So when we're talking about privacy, even within our patient population, we're talking about something that's rooted in common law. It's more of a legal right. When we talk about confidentiality, we're talking about things that apply to the data. So if privacy is looking at what information is collected and how that information is collected, confidentiality is looking at what do we do once we have that information. So, for example, medical records being kept in a locked cabinet, or now having electronic medical records. It's protecting that information and being very deliberate about who gets that information, when, why, under what circumstances. Okay, so confidentiality is usually refers more to an ethical obligation. So if privacy is the legal obligation, confidentiality is the ethical obligation. Within psychology, let me start here. I'm sorry. So privacy and confidentiality in all of service provision is something that's required and accepted as important. And if you look at DDD's listing of personal rights, it's the very first right that they list. So they say specifically, you have the right to privacy and respect, right? So so we recognize that that's important and that people have that right. And psychology in general accepts that it's fundamental. So I listed here, I won't read it word for word, but our code of conduct specifically addresses the fact that we are required to maintain confidentiality, that it's essential. So privacy and confidentiality really for all of healthcare is required, right? We know it's a legal and an ethical obligation, but specifically in psychology, it really is the bedrock of everything that we do. It's necessary, it's essential, it's non-negotiable. It's not always clear and specific about what it means. So there is some room for interpretation at times, but we cannot provide good quality treatment unless our patients feel comfortable to share with us, right? So when we protect privacy and confidentiality, we enable our patients really to trust us, because we're kind of the secret keepers, right? We're meant to be an objective person that a patient can come in and share all of their most personal thoughts and feelings with, and experiences, right? So when we protect that privacy, we enable our patients to trust us, right? And it enables us to provide the best quality of care, because when people trust us, they'll allow us to help them, right? So privacy and confidentiality really promote quality of life, well-being, empowerment, right? Remember, we said that privacy is control over who knows you and who knows about you. So it's empowering when we get to decide who knows something about me, right? And it promotes inclusion. So in psychology specifically, when we really maximize privacy and confidentiality, we're able to create a safe space for people where they can talk about anything and everything without fearing that they'll be judged or penalized in some way. Privacy and confidentiality also protect people from potential harms. So some of those harms might be psychological. So we're protecting people from feeling embarrassed or other types of distress. We may be protecting them from social harms. So things like loss of employment or damage to a person's financial standing, or maybe damage to social relationships. And we protect people, it helps protect people from criminal or civil liability. I think the important thing to keep in mind here is that protecting privacy and confidentiality can protect people from both predicted harms and unpredicted or unforeseen harms. So it's one of those things where the effects of protecting privacy or not protecting privacy, we can't predict all of the potential benefits of protecting it or all the potential harms of not protecting it. So these are some of the things that are generally affected by it, but we can never predict it. So it's important to protect privacy and confidentiality as much as possible, because the effects may be unforeseen, especially for each individual person. So the other important point is that protecting privacy and confidentiality within a psychotherapeutic relationship can also enhance or support other services. And I'm going to talk in a little bit about an example of where that really comes into play. So sometimes having a safe space where individuals can talk about personal issues gives them a chance to share something that maybe they couldn't share with a different service provider. And I'm sometimes then able to bridge that gap and help them learn how to make that communication. So in general, in psychology, and this also applies then specifically to my patient population, there are limits to privacy and confidentiality. And the first is duty to protect. So we have a legal and ethical obligation to protect patients from serious harm. So that generally refers to someone with suicidal intent. So if someone is expressing intent to kill themselves, I have a responsibility to enlist help or let someone else know to protect that person and keep them safe. The second limit to privacy and confidentiality is duty to warn. So I have a legal and ethical responsibility to protect the public from serious harm. So if a patient expresses homicidal intent, I have a responsibility to warn the potential victim. Psychologists are mandated reporters. So if we become aware of ongoing domestic violence, abuse or neglect of children, the elderly, or people with disabilities, we are required to report that. And then the last limit to privacy and confidentiality is a court order. So if a person's mental health comes into question or is the focus of a legal proceeding, then a psychologist like myself might be required by a judge to share a certain amount of information. And in those cases, we are legally required to cooperate with that and provide the information. But even then, we really try to provide the minimum amount, just what's required. Okay. So let's talk about some of the challenges to protecting privacy and confidentiality. This can be a challenge in the general community. So in general, in psychology, there are sometimes issues that come up that may threaten a person's privacy and confidentiality. But within the population of adults with intellectual and developmental disabilities, we really have some unique challenges to face. One of those is limited or unclear information. So when I was first preparing for today, I did a Google search because I wanted to see if I were either a patient or a caregiver, what information would be out there for me. If I had a question about, okay, if I go see the psychologist, are they really going to keep things private? Do I really, who are they going to tell? Wanted to see what information I could get. And it really was difficult to find anything really clear or specific. Part of that is the nature of privacy and confidentiality, just in general, that it's sometimes vague or unclear because each situation is unique and there's a certain amount of clinical judgment that sometimes goes into that. But I think also with a unique population, there isn't always that clear guidance. People are not sure what to do. So sometimes that information is limited. I think there's also oftentimes a limited understanding of the therapeutic process and privacy and why privacy is important. I've had a lot of questions over the years about why a patient needs privacy. And I think lots of times there's reluctance to let me have this time with a person to talk in private where no one hears what they're saying. And I think it really comes from people's apprehension about, well, what is this person going to say about me? What are they going to say about our group home? What if they don't tell the truth? I've gotten that question a lot. Well, this person doesn't always tell the truth. And what if they don't tell you the right thing? And the therapeutic process is not about judging not only the patient, but anyone else that they're discussing. I'm not there to judge anyone or get anyone in trouble. Certainly, as I said, if there's some type of abuse or neglect going on, of course, I have a responsibility. But in general, it's just meant to be a place where this person can come in and feel comfortable and say anything they want to say, right? So there's a lot of education that needs to happen oftentimes to help people feel comfortable with the fact that it's okay that this person is going to be behind closed doors saying whatever they want to say. When we look at this patient population, just the nature of having a disability and receiving the number of services that most of our folks receive really limits their privacy and confidentiality. So that control that we talk about with privacy, control over who knows us and who knows about us, our folks generally don't have that. Now, I'm going to preface this with, I'm not saying that people shouldn't have the information, right? We've talked about it even here, that about how important it is for everyone to share information and for everyone providing services to know about that person and be informed, right? It's very important. At the same time, each individual has no control over how many people get that information, right? They may be living in a group home where there are lots of staff, and maybe that agency does a great job of keeping all that information within the staff, and they're not talking to outside people about the clients, or they're not, going home and telling their families, right? But think about the number of staff that person will come into contact with over the years that they're there. And they're not hiring the staff. They're not choosing the people that get to know them and who read that big binder that has all their most personal information, right? Maybe it has their trauma history. It has every medical problem, every behavior, every mistake that they've made, right? So again, it's almost like a necessary evil from this perspective, where everyone needs to have that information. Everyone needs to understand that individual. But when they come into my office, they're now coming in from a place where they're not used to having privacy or confidentiality. They're used to, something happens and everybody knows about it, or, everyone talks about me. And so we kind of need to start from the ground up and, let them know that this is a place where things will be private. And you can tell me, what you're upset about or what's going on. And it's not going to be another piece of information sort of added to that big binder that every service provider sees. So along with that, living situations can really limit people's privacy and confidentiality. In general, kind of as that sort of foundation of where they're coming from, right? Because folks might be living in group homes or other places where they're living with other people that they didn't choose. But it also, as we'll talk about telehealth, it can also then affect in some ways who knows about their psychotherapy, right? We've had situations where there's limited staffing. So staff will bring not only the patient, but also their housemates. So now we have a situation where everyone in that house knows for sure that you come for psychotherapy, right? So again, it's one of those situations where logistics may necessitate that, but it's just something to keep in mind as far as where this person is coming from and the fact that their privacy is limited. Most of the patients that I see here at DDC have appointed guardians. They're not their own legal guardian. They have family members or other court-appointed guardians. And this creates a very unique and complex challenge to protecting privacy and confidentiality. This is one of the areas where psychologists don't have a lot of clear guidelines, and we use a lot of clinical judgment in this area. And generally what we do is we follow best practices for adolescents with guardians. The reason this presents such a challenge is that legal guardians have a certain right to information. Similar to, payers like insurance companies, they have a certain right to information about psychotherapy. So guardians have a right to a certain amount of knowledge. And so it really creates this complex situation where we need to provide people the information that they want or that they need, right? Because again, we're serving individuals who may need a lot of support. They have other people supporting them, and those people may need some of the information that we discuss in sessions. So we have to balance that with protecting this person's privacy and confidentiality, because if we don't, then we're doing a disservice to the patient. So it really creates a complex issue, and we'll talk in a second about how we address that. And then telehealth certainly has been an interesting challenge. Most of the patients that I'm seeing here at DDC continue to be remote. We continue using Zoom for our therapy sessions. And it's been great. The technology has been so helpful in allowing us to reach individuals when they weren't able to come into the office. But it really makes it more difficult to protect their privacy. When patients are here in my office, I can create a private space, right? I have control over the environment. When we're using Zoom, I have a whole lot less control. So there may be someone else in the room, or there may be someone listening at the door, and I may not know that, and I don't have control over that. Technological issues have created some challenges for privacy and confidentiality. So if someone is trying to use Zoom and the internet is unstable, they may be asked to go to someone else's bedroom and have a Zoom meeting from someone else's room. Or in some cases, people are going, outside, or trying to have sessions in a van on the way to another appointment. And I'm not trying to make anyone's life difficult when we don't have a session in a van, but it really is important that that person, as much as they can be in a private space. So that really has been a challenge, and I think I'm often seen as a stickler. I'm getting a reputation for really pushing privacy and confidentiality, but it's so important. And my patients and their caregivers and all my colleagues at this point know that I really am unapologetically protective of privacy and confidentiality. And it's not personal, it's not to give anyone a hard time, but it's really to advocate for the patients and make sure that they have what they need. Okay, let's see, I'm just keeping an eye on the time. Okay, so there are several measures that I take to try to maximize privacy and confidentiality, and I'm hoping that some folks will have even more ideas about how to do that. But some of the things that I do are what psychologists will do in general to protect privacy and confidentiality, and then some things that may be more specific to our population. So in general, as I mentioned, we create an environment that is private, right? So I meet with patients in an office with the door closed. It's just us. Sometimes, so I should preface, sometimes we'll have a caregiver join the session, but that's done strategically and with the patient's permission, but it's more the exception than the rule. But generally, we meet alone in an office with the door closed. We're out of earshot of the waiting room or other people that might be able to overhear our conversation. And so we really try to set up a private space. We use an electronic medical record, right, as many service providers do now. So anyone who is accessing that patient's information needs permission. They have to have a specific reason to access that information. Answering the phone, right? If someone calls and asks for a particular patient, asks their patient here, our response would be, we can't confirm or deny that we know that person. Whether or not they're a patient here, we use that same response for everyone so that it protects everyone's privacy, right? So a lot of those general measures that psychology takes to protect privacy and confidentiality. One of the most important things that I can do, which I do, is to discuss this issue at the very start of therapy. So whenever I see a new patient at that very first session, we discuss that patient's right to privacy and confidentiality. I think what makes it a little bit different, I think, for our folks than maybe in the general population, is that I spend a lot of time doing this. It's not just an item that I check off a list. It's a real discussion, and it's really important to me that that person understands what their rights are and the limits. So we discuss those limits to privacy and confidentiality. And that conversation very often, whenever possible, includes caregivers, either the guardian or whatever caregivers are supporting that patient at the time. We have that conversation together, and we come to an agreement right from the start about what will be shared and what will not be shared, and under what circumstances. So this way, everyone knows what to expect, and everyone can feel comfortable that that they are they're going to get the information that they need, and also that the patient's going to get what they need by having that privacy. One of the interesting things that's come up in the last year or so is that I've had a few cases where guardians have decided not to pursue services because of this very issue. So most recently, I had a patient whose mother wanted to be in every session. She felt that it was important for her to know everything that goes on with her daughter. And I understand that and I respect that. But it was a very complex situation, and actually a situation where I felt it was particularly important for the patient to have privacy and be able to speak without her mother in the room. So we really had extensive conversations. And in that situation, it was decided that services were not in her best interest at this time because she could not be given privacy. And so, my hope is that at some point, we'll be able to bring her back and get her some private time for therapy. But in many cases, without that privacy, it's really difficult to make any meaningful changes or to have a meaningful therapeutic process. So it's that important that if there's no privacy, I don't think that therapy can be helpful. In most cases, we're able to come to an agreement where everyone is comfortable, and it becomes an ongoing discussion. So as the patient continues in treatment, we adjust as we need. There may be times where maybe a group home will ask for certain information and we'll share that. There are times where I may give a homework assignment and the patient says, please don't put that on my after visit summary. I don't want the staff to know that that's my homework, and I respect that. So it's really individualized, and we take it on a case-by-case basis. The last thing I wanted to share with you today is an example recently of a case where privacy and confidentiality was really a central issue, and it took a little bit of investigating to figure that out. I had a patient where he was in his mid-30s, mild to borderline intellectual functioning, or intellectual disability, I should say, and severe physical disabilities. He lives with his parents, and I'm changing some of the details to protect his confidentiality, but lives with his parents and is dependent on them. They are his sole caregivers. And he lives with he lives with his parents, and he was seeing me for major depression. And over the course of many years, he's gone through many depressive episodes and been on medication. And they were, every year or so, would go through this cycle where they would increase the medication. It would be sort of a battle. Parents would want to increase the medication. The psychiatrist would want to increase it. He wouldn't, but he would agree to it. And then when he was sort of out of his depressive episode, he would really fight to reduce the medication again. And so we started working together, and he really just did not want to be on medication, but wouldn't explain the reason. So his parents contacted me, who are his guardians, and said, we're really concerned, and we want you to talk to him, and we'll call him Thomas. We want you to talk to Thomas and tell him that he needs this medication. So I went back to Thomas and I said, okay, I said, can I share this conversation with Thomas? Yes. So I went back to Thomas and I said, your parents contacted me because they're very concerned. And, you know, what do you think? They want me to tell you you should take the medication. I'm not going to do that. I'm not a doctor, you know, which is what I explained to the parents. But I did agree to discuss with you what your concerns are and why you don't want to take the medication. And we discussed it, and I brought up every issue I could think of. You know, was it stigma? Was it making him feel physically ill? And he just wouldn't say. And so, of course, I went home thinking about it and had an idea in the middle of the night, as I often do when I'm really thinking hard about a case. And I asked him, are you experiencing sexual side effects? And he froze. And I said, is it okay? I asked you about that. Can we, you know, is it okay that I'm talking about it? And he said, yes. He said, but I can't tell my parents that. And so we started talking. And what came up is that every meeting he has with the psychiatrist, his parents are always present. And he couldn't tell the psychiatrist about the side effect. He felt he couldn't because his parents were there. And so he really felt like he never had an opportunity to do that. So we talked, we practiced some problem solving, and we, you know, tried to come up with a solution. And because I'm in a unique situation at DDC where we work together as a team, I had access to the psychiatrist to, you know, just walk a few feet and have a conversation. And what I agreed with Thomas is that I would communicate to the psychiatrist that Thomas would like to have a few minutes to have a private conversation without his parents. And so that's what I did. And so I mentioned to the psychiatrist that Thomas had a personal issue that he wanted to discuss. And they went from there. Now, how they handled it from there is could be a whole nother presentation, but they were able then to figure it out. The psychiatrist was able to work with Thomas to kind of figure out a solution. But I love that example because I think it highlights the fact that, you know, how important privacy can be and how important it is for people to feel like they have a private space to share something very personal. And the fact that having privacy and confidentiality in psychotherapy can often help with other service provision as well. So hopefully that gives you a little bit of an idea of some of the ways that this is really important, and maybe some of the things that we can do to really maximize privacy and confidentiality. So thank you. Thank you all for listening.
So for Alicia, that was fascinating. And not only did you give us a little bit of an idea of the work that you do, you gave us a lot of an idea. There are a couple of questions if you're open to taking some questions right now.
Sure.
So when you had spoken about a person in a group home maybe telling you, you know, this person doesn't always tell the truth, and you learned something in the course of a session that might point to abuse or neglect, or even other maybe illicit or illegal behavior going on in a residential environment, what would your next steps be? Would you take that to DDD? Would you take that to the agency? Would you take that to law enforcement? How would you intervene in such a case?
I think it depends on the situation and the nature of what those allegations are. As part of Atlantic Health, truthfully, I would probably go to my manager for advice and to kind of get her input on that. Usually what people are, the concerns that people have had are things like this person argues with their housemate and they're not telling the truth about that. So fortunately, I haven't come across very serious allegations. It's been things like, well, this person steals coffee at work and they say they didn't. So it's usually something simpler.
So not to undermine it, but like a petty kind of thing, right? As opposed to, I mean, because let's just state for the record that you and I, from our experience, know that these agencies that manage these programs are of the most, are of the highest standard, and are really abiding by, all of the regulations. That I would like to just put that out there, because I know from experience how well managed these situations are. But if there was ever a case of something consumer to consumer, or with a direct support personnel, I don't know, sleeping during a shift or whatever, like anything that can happen anywhere. I'm just wondering if that's the kind of stuff that comes up in these conversations.
Yeah, usually not. There was a couple of months ago something minor. It was something akin to a staff member sleeping in someone's bedroom overnight. So something like that, I would mention to the supervisor, which I did. I contacted the supervisor, and then they investigated it. But fortunately, I haven't been made aware of anything more serious.
And that's great, because, the care that is being provided by these wonderful and doting direct support staff and their management is, it's to be applauded mostly,
Absolutely.
So, yeah. There's another question, but I just wanted to throw out to the chat, if anybody has. Hi, Leslie, welcome. I see you were able to get in. Does anybody have any questions for Dr. Mirra? So in terms of the psychotherapeutic relationship with your patients, you kind of answered the question when you gave the analogy of the conversation that you had with the psychiatrist. But in some cases, when a psychiatrist is looking to prescribe a medication and perhaps the patient is not very verbal or able to articulate what's going on, privacy notwithstanding, does anybody ever come to you and say, I'm trying to put my finger on how to help manage this behavior and I need more information from you? Has that occurred?
In terms of the psychiatrist?
Yes.
Coming to me? Yes, there have been times where we've had those conversations, and I, as a psychologist, part of my role is sometimes helping to monitor certain symptoms, right? So that's one of the ways that psychologists and psychiatrists work together, that I can sometimes monitor things from a behavioral perspective. I have to be careful because I'm not in the role of a behavior analyst. I don't have the same ability to track behaviors as intensely, or to require staff to do that monitoring. So it's a lot of times it's a balance. And sometimes in many cases I've worked with the behavior analyst, that we've kind of worked together. And sometimes I can help them tease apart what is a quote unquote behavior and what is a symptom. So for example, I have a patient who becomes very agitated when she's depressed. One of her symptoms is agitation. And we know that within our population, very oftentimes mental health issues, right, or psychiatric symptoms can sometimes be manifested in ways that are different than generally in the general population. So sometimes I can help them tease those things apart, and it makes a big difference in how you address it, right? So agitation from depression, you're going to address very differently than agitation because I'm trying to access a tangible, right?
Yeah.
So that's kind of one of the ways that I can help out in that area. Sometimes I've had patients who their symptoms, let's say depressive symptoms, are related to their medical conditions. So I have a patient with PKU, and as soon as I see that he's becoming a little bit depressed, I let his doctor know, because then they know to check his labs to see what's going on with the PKU. So I'm in that position to kind of bridge the gap, but I have to be really careful to, then to not overstep and not be practicing outside of my area. I'm not sure if I answered your question, Laura.
No, you did. That's wonderful. Okay. But you're clearly an excellent resource for a psychiatrist who is seen less frequently than who sees the patient less frequently than you would, right? Because typically that would be for medication management, right?
Right. Yes.
And there would be an evaluation and then titration of medication. How frequently do you see the patients?
So it varies. Generally, I see patients either every other week or every week. I have a handful of patients that I see every week. Usually it's every other week, partly because for a lot of these folks, it's too much. Every week is too much. Plus, I know there are a lot of logistical challenges.
Yes.
I have some patients that I see once a month or once every few months, just to kind of check in and for maintenance. And I have some patients who I would love to see every week, but we meet less often because they have to miss part of their day program, and they love their day program. And for
also,
some of my
you've
patients,
got the staffing ratio is an issue too, right? If you pull a staff away to go with one consumer.
Absolutely. So I'm very flexible, and having been in the group homes and in vocational programs, I understand all of those challenges. So we try to work around that as much as possible. And if it's someone who I know their day program is really important to them and they don't want to miss their day program, we try to really save them a 3:30 time slot or a 9:15 to try to minimize how much they miss their day program.
Right. Right. Well, we are getting to time. I just want to clarify for those who came on late and didn't hear the introduction. Dr. Mirra, she has a PhD in clinical psychology, specializing in intellectual and developmental disabilities. That is quite a specialty, and you are quite a resource. So if anybody ever has any questions or needs more information, again, we will be posting these slides. Michelle Jansen at the end of the series will be sharing out links to all of the resources from all 8 weeks. We will be posting them on the North Jersey Health Collaborative Resource Library. Dr. Mirra, thank you for this inspiring and insightful presentation. I learned a lot today. I'm sure our group did as well. We will be closing out our series next week, week 8, and boy, have these 8 weeks flown by. Next week, we have Deborah Spitalnik, Dr. Spitalnik, PhD from the Boggs Center for Developmental Disabilities, and she will be capping off our series on a discussion on healthcare policy and people with developmental disabilities. We all need to be advocates. So thank you, Alicia, for being an advocate.
Thank you.
And oh my gosh, it's a pleasure. And we also had on today as one of our guests, Catherine Thompson, advanced practice nurse, also at the Atlantic Health Center for Developmental Disabilities. So thank you both for the great work that you're doing for individuals with disabilities. Thank you all for coming on today, for the work that you do each day. And we will see you all next week. Have a great one and stay dry.
You too.
Make it a
Bye.
great day,
Thank you.
everyone.
Bye. Thank you, everybody. Thank you, Michelle.